Assalamualaikum, dah cukup orang ke?
Waalaikumsalam. Dah, doktor.
Okey, habis start lah. Kita start dengan Al-Fatihah.
Assalamualaikum, Doctor. Today, our group will be presenting procedure seminar 3. Next slide. Okay, these are our list of topics for today, starting with ECG, bone marrow aspiration and trophine biopsy, CPR in children, and lastly, CPR in infant. My name is Sita Arisha, and I will be presenting about the ECG. ECG is a recording of electrical activity, which is generated during and after activation of various parts of the heart, and it is detected by electrodes which are placed on the skin. There are three main types of ECG. The first one is resting ECG, which we usually done it in the ward. The second one is stress or exercise ECG, and the last one is Holter monitor, which is continuous ECG monitoring for 24 hours or more. And ECG composed of 12 leads, which is 6 limb leads and also 6 precordial leads. So what are indications for ECG in pediatrics? First of all, syncope or seizure, exertional symptoms, drug ingestion, arrhythmia, patient with cyanotic episode, diagnosed with heart failure, hypothermia, electrolyte disturbance, Kawasaki disease, aromatic fever, myocarditis, myocardial contusion, pericarditis, post-cardiac surgery, and also patient with underlying congenital heart defect. For complications, generally, ECG is safe because it is non-invasive and painless, so it causes no major risk. However, if there is complication, it can cause mild rash or skin irritation at the placement of the electrodes. So this is example of the ECG strip. The standard ECG recording is 10. The strip is about 10 seconds length. The paper speed is 25 millimeter per second, and one small square is 0.04 seconds. So one large square composed of 5 small squares. So that's why one large square is equal to 0.2 seconds, and 1 millimeter vertical is 0.1 millivolt. So if you look at the right picture, our normal electrical conduction of the heart will start at the SA node, and then it will pass through the both atrium and then through the AV node, and then further into the bundle of His, right and left bundle branches, and then go through the Purkinje fibers, and also lastly both ventricles. So if you look at the ECG strip, there is P wave, QRS complex, and also T wave. The P wave indicates the right and left atrial depolarization, QRS ventricular depolarization, and T wave is ventricular repolarization. When we interpret ECG, first of all, we must look at the heart rate. How to calculate the heart rate? 300 divided by the large box between the two RR interval. And then the second one is rhythm. The third one is timing intervals. We look at the PR and QRS duration. Normally, the PR lasted for 0.12 to 0.2 seconds in about 3 to 5 bots, small bots, and QRS complex is less than 3 small bots. And then we look at the heart axis and the P wave morphology. Is there any absence or presence of P wave? If there is presence, it indicates the sinus rhythm. And then the QRS morphology, and lastly the ST segment, which is supposed to be isoelectric line. In pediatric ECG, some findings that is found to be abnormal in adult may be normal in pediatrics. For example, the heart rate, which is more than 100, because pediatric usually has heart rate which is more than 100, for example in newborn up to 150. And then the second is right precordial T wave inversion. Dominant right precordial R wave, short PR and QT intervals, short P wave, and also inferior and lateral Q waves. All these are normal in pediatric patients. For ECG equipment, first of all, we must take the ECG machine, and then the electrodes, the limb leads, and also the precordial leads, ECG paper, and also the ECG gel for placement of electrodes, and also cleaning wipes after the procedure. So for methodology, first of all, we must remove all the jewelry and avoid any skin cream or oil prior to the procedure, and then remove patient's clothing and ask patient to lie on bed in supine position. And then we can start place the limb leads and also the precordial leads as in the picture. For the precordial leads, we have 6 precordial leads, V1 until V6. For the V1, it can be placed in the 4th intercostal space on the right sternum, and then V2 at the 4th intercostal space on the left sternum. And then before V3, we place the V4, which is at the 5th intercostal space, left mid-clavicular line. And then V3 is placed between the V2 and V4. V5 is placed at the anterior axillary line on the same horizontal level as the V4. And the last one is V6, which is placed at the mid-axillary line. So after we place all the precordial leads and also the limb leads, we key in the patient information and we push the start button on the ECG, and then we wait for the strip to come out for about 10 seconds. So after the strip is done, we disconnect the leads and remove the electrodes, and we can label if the ECG machine is unable to key in patient's information, we can label the strip name of patient's name. Next slide. Okay, this is short video on ECG placement. So this is placement for ECG. We can locate the intercostal space by looking at the angle of Louis.
This can help reduce electrical interference. Perform hand hygiene. The patient should be in a supine position with all limbs supported and an exposed chest. No muscular work should be required on the patient's behalf to maintain the position that they are in. Prepare the skin. If the patient's skin is dirty, clean with soap and water and then dry. Patients with chest hair should have hair at the electrode placement sites removed. If the skin is oily or the patient applied any creams or lotions, use an alcohol wipe to clean each electrode placement site. Placement of electrodes requires correct anatomical identification. Angle of Louis method for ECG placement. To locate the space for V1, locate the sternal notch, angle of Louis, at the second rib and fill down the sternal border until the 4th intercostal space is found. V1 is placed to the right of the sternal border and V2 is placed at the left of the sternal border. Next, V4 should be placed before V3. V4 should be placed in the 5th intercostal space in the mid-clavicular line, as if drawing a line downwards from the centre of the patient's clavicle. B3 is placed directly between B2 and B4. B5 is placed directly between B4 and B6. B6 is placed over the 5th intercostal space at the mid-axillary line. B4 to V6 should line up horizontally along the 5th intercostal space. Ensure limb electrodes are symmetrically placed. Connect the leads to the electrodes. Calibrate the ECG machine and obtain the ECG trace. Remove the electrodes and gel, clean equipment and dispose of electrodes.
Okay, so that's how to perform the ECG. That's all from my part. Is there any question?
Okay, any questions? Now, basically, ECG is very important. Okay. In fact, it can be used to diagnose a lot of congenital heart disease. For example, you can use ECG to diagnose things like Epstein anomaly, ASD, because of course echo need is a more technical, expertise. But ECG can be performed by anyone, but interpretation of ECG is a bit difficult. So, but with ECG combined with chest X-ray, you can actually diagnose a lot of congenital heart disease. Okay, any other questions? So when in which condition you need to use ECG? I mean, ECG helps in diagnosing. Can you name few?
For example, in patient with established Kawasaki disease or patient with rheumatic fever, because they can also present with cardiac complications such as pericarditis.
Kawasaki, what sort of ECG changes do you expect in Kawasaki? See, there's no role. I think in Kawasaki, there's no role for ECG. In rheumatic fever, rheumatic heart disease, there is a role, because it's one of the criteria, kan. Problem PR is a minor criteria for, it's a sign of carditis. Okay, what else? Besides cardiac problem, when do you have to do ECG?
In patient with electrolyte abnormalities.
Very good.
Because it depends. For example, if patient is symptomatic, it depends whether if there is any ECG changes or not. It depends on the management.
Okay, good. Okay, good. Okay, okay lah. Itu juga. Next.
Assalamualaikum warahmatullahi wabarakatuh. Can everyone hear me? Okay. So I'm Nadira. I'll present on the bone marrow aspiration and refined biopsy. Next. Okay, so for the definition, basically the bone marrow aspiration and refined biopsy are different. Bone marrow aspiration means we are removing a sample of liquid of bone marrow. Meanwhile, for the trephine biopsy, it is a solid removal, a core sample of the bone marrow. For the aim of bone marrow aspiration, it is to evaluate the microscopic morphology of the cell as well as to define the differential counts of the cellular in the bone marrow. Meanwhile, for the biopsy, we want to focus more towards the architecture of the bone marrow. We want to see how the bone marrow appears. Next. Okay, there are certain sites where we can take the bone marrow aspiration and bone marrow biopsy. Basically for the bone marrow aspiration, there are 4 sites that we can take. The first one is posterior superior iliac spine, and then anterior superior iliac spine, sternum as well as tibia. But for the bone marrow biopsy, we can only take it from the PSIS and ASIS. The reason is because if BMB or the biopsy is taken from the sternum, it can cause further injury to the mediastinal structure. So the PSIS or posterior superior iliac spine, it is the most preferable site for us to take the aspiration or biopsy because it is the safest, the least pain, and it has the easiest access. And then the second option that we can choose is the ASIS. But the ASIS is usually only be taken if PSIS is unfavorable because of several reasons. For example, if there is infection on the PSIS, or maybe there is injury in the PSIS, or maybe due to the morbid obesity. Because when there is a lot of fat, it will be accumulated in the gluteal region near to the PSIS. And then sternum, yeah, we only take sternum if both PSIS and ASIS are affected by the infection, for example. And then for sternum, we only take from children older than 12 years old. For tibia, usually anterior tibia, we only take from the children less than 18 months old or less than 1 year old, because at that time the bone marrow is not hardening yet. But beyond that age, usually the tibia already hardened, so it is quite difficult for us to take aspiration from that side. Next. For the indication of bone marrow aspiration, the first one is we want to investigate the children with abnormal peripheral blood finding, for example, if there is any elevated blood cell, or maybe pancytopenia or unexplained anemia, leukopenia or thrombocytopenia in the child. The second one is we want to diagnose if there is hypoplastic anemia, malignant hematological disorder, or metastatic expansion of tumors and congenital bone marrow deficiency syndrome. The third one, we want to achieve culture if the patient is suspected with fever of unknown origin. And then we want to do further evaluation if the patient came with abdominal mass, hypersplenism, as well as lymphadenopathy. And then we want to do follow-up of treatment. For example, like chemotherapy or hematopoietic stem cell, we want to see how was the progression and the response towards the treatment offered to the patient. Next. Indication for trephine biopsy. The first one is if the bone marrow aspiration is inadequate. For example, if there is dry tap from the bone marrow aspiration, then we can go for trephine biopsy. The second one is if the bone marrow is fibrous, then we want to do the bone marrow biopsy as well. Bone marrow biopsy is also used to stage and evaluate the Hodgkin and non-Hodgkin lymphoma. The reason is because we want to see how the lymphoblast is actually appear at the bone marrow, because it can tell how what is the stage of the Hodgkin lymphoma. However, some studies do not suggest that biopsy has a prominent role to decide the stage of the Hodgkin lymphoma. And then trephine biopsy is also used to diagnose aplastic anemia or bone marrow failure, myelodysplastic syndrome, as well as acute megakaryoblast leukemia. Next. So bone marrow aspiration and bone marrow biopsy are also contraindicated in certain conditions. For example, like hemorrhagic disorder, for example, in patient with severe hemophilia, disseminated intravascular coagulation, and patient on anticoagulant. However, this can actually be anticipated, or how we can actually act to this patient is by preparing the patient with factor 8 concentrate, for example, and then we can stop the anticoagulant. It's just that we need to appropriately prepare the patient. The second one is skin infection or recent radiation therapy at sampling site. And the third one, if there is any bone disorder like osteomyelitis or osteogenesis imperfecta, we should avoid doing bone marrow aspiration and biopsy because it can cause iatrogenic injury to the patient. Next. For the complication, there are several complications of bone marrow aspiration and biopsy. The first three are the most important: bleeding, infection, and pain. Because this is invasive procedure. And then it can also cause gluteal compartment syndrome. And then needle breakage. But it is not that common. Tumor seeding, for example, if patient is having malignancy, the site of where we puncture the needle, we can actually lead towards tumor seeding over that area. And then for pericardial tamponade, it is usually associated with sternum bone marrow aspiration, whereby the doctor might accidentally go beyond the posterior surface of the sternum, so it can actually injure the pericardium. Next. For the equipment, for bone marrow kit, usually there will be sterile drapes, but sometimes there are hospitals that didn't use drapes, but they are using the aseptic technique. And then there should be needles, syringes usually for the aspiration, and then aspiration needle. As you can see in the picture, the picture below, aspiration needle, the blue color one. Yes, that one. That is the aspiration needle. For biopsy needle, is the one below it. The T shape as well. Yes, that one. That one is the biopsy needle. So you can differentiate it. Aspiration needle usually it has like extension of the blue color one. And then usually we are using the Jamshidi needle for the bone marrow biopsy. And then we need to prepare 1 to 2% lidocaine, which is the local anesthesia, with or without epinephrine. And then we need to prepare the specimen slide and specimen container depend on what type of pathology under investigation. So next. So this is the picture of aspiration needle. As you can see that there is guard, stylet and needle. So it is quite different from the biopsy needle, because in biopsy needle usually we didn't have the guard. Next. Okay, next. So please differentiate between the aspiration needle and biopsy needle. So the below one or the left one is the aspiration needle. On the right one, it is the biopsy needle. Okay, next. Next. Okay, for the methods and steps. So for the first one, we need to identify the patient first. Need to confirm the identification of the patient or the parents, and then we need to obtain the consent. But usually, for this kind of procedure, we already have the consent. We just re-inform the patient or the mother about the consent that has been granted previously. And then we need to prepare the patient. So for children, usually we need to sedate the patient. So we can give midazolam, but for midazolam, we need to anticipate the respiratory depression that it may cause. We need to position the patient previously before the bone marrow aspiration picture. Okay, so we can position the patient either in a prone position or left or right lateral decubitus, because we want to make the posterior superior iliac spine to become prominent. And then if we want to take from the sternum, we need to position the patient in a supine position. And then we need to identify the landmark. And then we need to don the PPE, wearing the glove, the apron, and then organize the equipments. And then for the anesthesia, as mentioned just now, we need to use the lidocaine, right? And then we need to pair it either or not with the epinephrine. However, when I searched, I'm not really sure the main role of epinephrine in the anesthesia, because from what I read, the epinephrine is used as a prophylaxis towards the anaphylactic reaction of the lidocaine. But I'm not really sure if it is given together, because in the paper it said that the epinephrine is given after anaphylactic reaction has actually occurred in the patient. And then for the step, we need to do small incision to avoid the injury. And then next, Sister Daya, next, for the bone marrow aspiration, as you can see, you need to pierce skin, cortical bone, spongy bone, and bone marrow. So we need to properly angle the needle, and then we can advance the needle into the bone. Initially, we can feel some resistance because it need to pass through the cortical and spongy bone. But once it has reached the marrow, there will be less resistance over there. And then we can take the aspiration. For trephine biopsy, usually we are using the same site where we puncture for bone marrow aspiration, because usually aspiration and biopsy, they are concurrently taken together. The difference between the bone marrow aspiration and biopsy is just that for biopsy, we didn't use syringe. We are using they call it like spoon that will be inserted into the trocar, and then it will take the as the bone marrow out from the patient. Next, let us see the video on how it is done.
The procedure starts by finding the correct level for the biopsy. The biopsies are taken from the upper iliac crest with access via the ventral spine. The midline of the spinous process is identified and the iliac crest is located by palpation. When the correct point is found, the puncture point is marked using a straw. This is to avoid losing the marking after washing. The area around the puncture point is washed with colored chlorhexidine. The procedure is carried out aseptically, but without sterile drapes. The area around the puncture point must remain sterile during the whole procedure. Correct placement of local anesthesia is important for how the patient experiences the procedure. 10 milliliters of xylocaine with 10 milligrams per milliliter of adrenaline is normally used. When the needle reaches the periosteum, the anesthesia is given time to work before the numbed area is expanded by angling the needle in 4 directions. To avoid unnecessary trauma to the skin from the aspiration needle, a small incision is made in the skin with a scalpel blade. Disposable and reusable aspiration needles are available. A reusable needle is used in this video. The needle is pushed toward the posterior iliac spine and rotated with careful pressure until it goes through the cortex. When the needle is in the spongy tissue, the trocar is removed and a 5 milliliter syringe is connected to the needle. 0.2 to 2 milliliters is quickly aspirated for a regular bone marrow smear. 3 small and 7 larger smears are placed on slides. The slides are tilted and the blood, which collects in the lower edge of the smear, is removed before it coagulates. We then use another slide to make a few regular smears and some which are squeezed. The smears are dried with a fan before fixation and staining. A new aspiration needle is used for aspiration for flow cytometry. 0.5 milliliters of monoperin is placed in the syringe in advance to stop the aspirate coagulating. 4 to 5 milliliters is aspirated with the syringe. The aspirate is quickly moved to a specimen glass. Finally, a punch biopsy is taken. A disposable needle is used. The needle is inserted in the same puncture wound and pushed toward the posterior crest. The needle is rotated with constant pressure until it penetrates the iliac crest. Care is taken to ensure that the needle does not slide into an area that is not anesthetized. The trocar is removed from the needle. The rotation of the needle is continued until it has penetrated deep enough into the bone marrow. The spoon is inserted into the needle. The biopsy needle is rotated without pressure in both directions to cut the biopsy loose. The needle with spoon and biopsy is pulled out. The spoon is carefully removed from the needle and the biopsy is put in fixation fluid using a blunt trocar. The incision is closed with strips and covered with an adhesive bandage.
That's all for bone marrow biopsy and aspiration. If there is any question you may ask, thank you.
Okay, you asked about the adrenaline kan. The function of adrenaline is actually to reduce the blood flow around that area so that the local anesthetic will remain longer. Okay, understand kan?
Oh, I see. Okay, doctor. Noted. Thank you.
By the way, we don't do this like in pediatric. Okay, usually the patient will lie supine, and then we take from the back lah, and totally sedated. This one, not sure. Adult maybe they do this. I don't know. Okay, can I have the questions? Ada soalan? If not, then move on.
Assalamualaikum warahmatullahi wabarakatuh. I am Nur Hidayah binti Muhammad Kamal. I am going to present about CPR in children. CPR is cardiopulmonary resuscitation. Is an emergency procedure that is done to improve the survival of a victim due to cardiac arrest by receiving early help to restore the circulation and also the breathing in the victim. And when a person have a cardiac arrest, survival will depend on how immediate the person in getting CPR from the someone nearby that see that the victim is having cardiac arrest. CPR that is performed in the first few minutes of the cardiac arrest can double or triple the person chances to survive. And also in adult, CPR is typically needed due to a sudden cardiac arrest resulting from heart attack, while in pediatric cases, children usually needed CPR due to respiratory failure that leads to cardiac arrest, such as due to choking. So before going on to the next presentation, we know that children, from the definition itself, age more than 1 year up to weight of 55 kilogram, or in the presence of the sign of puberty such as breast in female and axillary hair in male. So indication for CPR in children is that when we see that the child is unresponsive or is having cardiac arrest, by the definition of the child doesn't have pulse, and also child with bradycardia with heart rate less than 60 beats per minute with reduced perfusion. And the contraindication for us to not do the CPR is that if the legal guardian had signed for DNR for the patient, and if we suspect the patient to have impending death, such as patient with severe motor vehicle accident, or patient with open chest wound or open heart wound. The complication of CPR itself comprises of rib and sternum fracture due to the compression, and this fracture can further cause pneumothorax, hemothorax, and pulmonary contusion. And lastly, CPR itself can cause aspiration because we introduce when we introduce ventilation to the unresponsive child, there will be gas accumulation in the stomach, so it can cause vomiting, and when the patient vomit, it can compromise the airway system and also can cause aspiration to the lung, and then this will cause infection. And when to stop compression after when doing the CPR is when the child regain consciousness, the child start breathing, and also if the help from help arrive, such that the defibrillator arrive, or also if there is more expert person arrive the situation, and also if the performer is exhausted from the compression. The equipment needed for CPR is PPE, such as glove, apron, or mask, if available, back mask device for the ventilation, and automated external defibrillator (EED) for the last step of CPR. And if the patient is suspected or confirmed to have COVID-19, we need to the performer need to wear the PPE before entering the patient room, and we need to limit the personnel who are performing the CPR, and to provide the rescue breathing using a back mask device with a HEPA filter, and ensure a tight mask seal. So the step in performing CPR, we have a mnemonic of doctors A, B, C, D. That is danger, response, send for help, and then to assess the airway, assess the breathing, do the compression and the CPR itself, and to wait for the defibrillator. The further explanation I will provide it in the video. This is the video of the summary of doctors A, B, C, D, CPR in children.
First of all, check for danger. Make sure that you are safe, they are safe, and those around you are safe. Next, check for response. Open your eyes, open your eyes, open your eyes. We want to see if they are conscious or unconscious. If they are unconscious, we move on to the next step. S is sending for help. You need to call emergency services immediately. Call for an ambulance to come and assist you. Don't hang up, stay on the phone, be calm and follow their directions. Next, clear and open the airway. In a child, we're going to do a head tilt and chin lift. But first, look in their mouth. If they have vomit or other objects, gently roll them on their side, let that drain out or clear from the front of the mouth. No big finger sweeps. Roll them back, tilt their head back and lift their chin towards the ceiling. Keep holding their airway open. Next, check for breathing. We are going to look, listen and feel. Get down nice and close. Look for rise and fall of the chest or tummy. Listen for air coming out and feel with your cheeks. We're not looking for a complete absence of breathing. If their breathing is abnormal, if they are gasping or taking shallow breaths, or if there is no breathing at all and they are unconscious, we need to commence CPR. C is for compressions. Do not check for a pulse. It's not about a heart that's stopped, it's about a heart that is beating ineffectively. To do compressions in a child, 1 or 2 hands over the centre of their chest on the hard breastbone. Push down 1/3 the depth of their chest at a rate of 100 to 120 compressions per minute. That's almost 2 a second. We're going to do a ratio of 30 compressions to 2 breaths.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Open up the airway. Breathe. Breathe.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Open up the airway. 1, 2. If there is a defibrillator available, use it. If you are by yourself, continue on with CPR only. If there is another person available, send them to go and get the defibrillator and follow its prompts. You do not need to be trained to use it.
Okay, from the video itself, we know that the performer use 30 to 2 ratio of compression to breath ratio, but it is mentioned in PITS protocol that we need to use 15 to 2 compression to breath ratio during the CPR for children. According to Malaysian guideline of resuscitation, it is mentioned from the International Liaison Committee of Resuscitation that they recommended 30 to 2 compression to breath ratio in a single performer doing CPR in children, and 15 to 2 compression to breath ratio for 1 or 2 performer in the healthcare provider. And I have read in the journal that why international use 30 to 2 rather than 15 to 2. It is because 30 to 2 ratio comprises of less mistake. The most common mistake that is done during the compression is that the performer forgot to give the rescue breath, and also the performer do not ask for help or too late to ask for help from the surrounding. And compression with 30 to 2 ratio have a higher adequacy in airway opening rather than 15 to 2, and the adequacy of ventilation is higher in 30 to 2 compression. And from the study itself, more than half of the performer of the CPR in children prefer to use 30 to 2 ratio because when we do a 30 to 2 ratio, we can get the rhythm in doing the compression rather than 15 to 2 ratio. However, the ratio of 15/2 is preferred in infant because the compression in infant is different from the compression in children. So the further CPR in infant will be explained by my next colleague after this. This is my reference for CPR in children. Any question?
Any questions? So this is quite straightforward lah to remember. In general, if you're alone, then do 32. If you're in hospital, we do 15-1. 15-2. Okay, any questions? No, eh? Okay, next.
Assalamualaikum warahmatullahi wabarakatuh. My name is Sharifana Hati binti Said Bogata Coffee. I continue the presentation on CPR in infant. Next. Okay, this is just quite the same from the previous presentation. CPR is the cardiopulmonary resuscitation. Is an emergency procedure that involves chest compression and rescue breath or artificial ventilation to help to deliver oxygen to the brain and other organs until further measures are taken to restore the spontaneous blood circulation and breathing in a person who is in the cardiac arrest. Infant is those who are less than 1 year old. So as you can see from the picture, CPR is a critical step in the chain of survival, and a strong chain of survival, it can improve the chance of survival and recovery for patients of cardiac arrest. Next. These are the indications of CPR, which are the cardiorespiratory arrest. In infants, they are more on respiratory insufficiency rather than the primary cardiac problem itself, and a bradycardia with a pulse of poor perfusion. Next. The requirement in the hospital setting, CPR may need valve mask and AED. However, in outside of the hospital setting, we can start CPR without any equipment. Next. This is step by step for a CPR by using the mnemonics of doctors ABCD. Firstly, ensure the safety of rescuer and also the child. Wear PPE such as glove, apron, mask if available. Look out for the blood spills, shocks, and also electric wires. Ensure that the external environment is safe for the child. Then check for the child's responsiveness. Gently tap the child and ask loudly, "Are you alright?" And then if the child responds or by answering or by moving, then leave him in the initial position and seek for help. Reassess the child, the infant regularly. If the infant does not respond, then shout for help. By saying out loud, emergency, bring the resuscitation trolley and defibrillators. However, if you are alone, start CPR immediately. if we are outside of the hospital setting, point the person nearby to call for 999 and also bring AED. Then open the airway by head tilt chin lift maneuver. However, do not overextend the child's head as it can obstruct the airway. If the child has a neck injury, do jaw thrust. Then check for breathing by look for chest movement, listen for breath sounds at the child's nose and mouth, and feel for air movement on our cheek. This should not take more than 10 seconds. If the child breathing normally, then put the child on the recovery position and go to seek for help. However, if the child breathing is not normal or absent, give 5 initial rescue breath. Then check for pulses. If the child pulse is less than 60 beats per minute and there are signs of poor perfusion or no signs of life, start chest compressions. Next. Next slide. As for the chest compression, as has been mentioned by the previous presenter, there is insufficient data on the optimal compression ventilation ratio for CPR in infants. However, Dr. has said that if there is only one rescuer, then do 30 to 2 compression to a ventilation ratio. However, if there is 2 rescuer, do 15 to 2 compression ventilation ratio. For the chest compression, we must push hard and push fast, allow for full chest recoil after each compression, minimize interruptions of chest compressions, less than 10 seconds, and also avoid excessive ventilation. As for the technique, for one rescuer CPR, compress with the tips of 2 fingers, as you can see from the above, from the atas tu, the above picture. For 2 rescuer CPR, 2 thumb chest compression, or also known as encircling technique, is used by putting our thumbs on the chest and encircle our fingers on the infant's chest and start the compression. As for the site of compression, at the lower half of the sternum, at least 1/3 depth of the chest or 4 centimeter depth, with the rate of 100 to 120 compression per minute, and the ratio for compression to breath either 15 to 2 or 30 to 2. And next. As for the ventilation, back mask ventilation remains the preferred technique in the hospital setting. Usually in the hospital setting, mouth-to-mouth ventilation is not done. However, outside of the hospital setting, mouth-to-mouth ventilation can be done. However, due to current pandemic, it's recommended to use protective device. Currently, we have a mask where we can use the mask to deliver the rescue breath without direct mouth-to-mouth contact. Next. So CPR can be stopped if the victim recovers with normal breathing. If the victim recovers with normal breathing, put them into recovery position, as you can see from the picture. Then if the rescuer is housed or if the advanced life support assistant arrive, and we must remember to switch. The rescuer must always switch the role of chest compressions every 5 cycles or 2 minutes in order to avoid exhaustion. Next. These are the complications of CPR, such as bruise or pain to the abdomen or chest, which may need analgesic, rib and sternal fracture, lung injury, including the pneumothorax or lung contusion, pericardial tamponade, aspiration, and also aortic laceration. Next. Let's us watch on how to do a proper CPR in infant.
Welcome to today's video on healthcare provider BLS for the infant. Let's take a look at what those steps look like, shall we? Hey Doc, Okay. Who throws a baby? Step 1, establish unresponsiveness. 2, assess for breathing. If this infant is not breathing, call a code immediately, get some help coming. You look, cutie. And you're unresponsive. And you're not breathing. Nurse, call a code, I need some help in here. Next, check for a pulse. Check for no more than 10 seconds. If this infant does not have a pulse, immediately begin chest compressions. Check for a pulse. I got no pulse. Great. That's fantastic. My kingdom for 2 nurses right now. There goes my kingdom. I need you guys to take over CPR on this little one. You ready? Yes. Now, in 2 rescuer CPR for the infant, the way we perform compressions is with a circumferential grip. Our thumbs on the sternum between the nipple line, and we're going to compress about 1/3 the distance anterior posterior of this kid's chest. So almost halfway through this kid's chest you're pushing. Again at a rate over 100 and a compression to ventilation ratio of 15:2. Okay, remember, we're going to do our compressions 15:2, 15 compressions, 2 breaths of air. Watch for that chest rise. Good. Circumferential grip. Remember, you're going to compress about 1/3 the distance through that kid's chest, okay? This is an infant, not a child. Now, if all you have is an adult BVM, you can still ventilate an infant. Take the mask and invert the mask. Turn it upside down. So on the adult, where the nose would normally be, we're going to spin that over and we're going to put the nose section down by the infant's chin. The face mask will then come up and cover the rest of the face. You're going to have to cut down on the amount of volume you give this infant, and we're just looking for a little chest rise. That's all. But again, if all you have is an adult mask, you can still ventilate an infant by inverting the mask.
Okay, before I stop the presentation, I would like to add the contraindication for CPR, like as we mentioned before, is do not resuscitate order, and also in infant, when we want to check for the pulse, we can feel for the brachial pulse or femoral pulse, and it should take no more than 10 seconds to check for the pulse. Okay, that's all from me. Thank you. Any question?
Okay, any questions? Any questions?
Doctor, I have a question. Okay. Bila infant tu dia tak responsif lepas tu bila kita check dia punya pulse, dia ada palpable pulse more than 60 beats per minute, tapi tak cukup inadequate breathing. From my reading, it said that just continue to give rescue breath at 12 to 20 breath per minute. Tak payah bagi chest compression. Betul ke?
Yes, true. Kenapa? Why do you want to give chest compression? Heart rate ada kan? So kenapa you nak bagi chest compression? In adult, okay, in adult, for example, you've got an adult unconscious, not breathing, but got heart rate. Do you give chest compression? Okay, like in general, in pediatric kan, pediatric, we know even though they still got heart rate, we will do CPR. Faham tak? Because 60 tu is too low for them. They won't be able to sustain good circulation and oxygen delivery with 60 or even less. But in a dog, if the heart rate is like 60, you don't do CPR. You only do CPR if there's no heart rate. Faham kan?
Sekejap doktor. Maksudnya kalau patient tu 60 beats, infant lah, buat je CPR.
Kalau what? Kalau what?
Tadi dah cakap kalau beats kan, kalau 60 beats insufficient So start the CPR.
No. You give rescue breath first. Kalau continue persistent less than 60, then only you ni lah. You guys, year 5 ke year 3?
Year 5.
You learn NRP kan? Do you straightly do CPR ke in baby? No kan? You give breath first. In pediatric,
bagi breath.
usually the pathology is respiratory. Okay, in pediatric cardiac arrest, most of the time the problem is respiratory because the heart and the lung is mainly controlled by your parasympathetic because they've got good lung kan? They've got good lung, good heart in pediatric. Okay, so you would expect most of them cardiac arrest because of lung pathology. So with breath, a good breath, good oxygenation, kan, they can recover lah. The heart rate can recover, the heart pumping. But not in adult. In adult, majority of time, cardiac arrest is due to heart problem, primary heart pathology. So you need CPR, you need chest compression. Actually, you try lah. Nanti later you jumpa someone adult collapse on YouTube lah, 1 juta kali, you won't do any effect. Because it's primarily heart. But in pediatric, it's primarily lung. So we give chance. Kita bagi ni. However, but if the heart rate less than 60, we know they cannot sustain the oxygenation and they cannot sustain the blood circulation, tissue perfusion. So you need to do CPR. Okay, faham? Faham kan?
Faham doktor.
Okay, soalan. Last kan ni kan? Kan? Done right? Finish. Okay lah, nanti I give you the mark.
Okay, doktor.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Okay, kita start lah.
Thank you, doktor.
Okay, tangguhkan atas speaker Farah. Instructor Nas. Okay, do email me the slides. Okay, Assalamualaikum warahmatullahi wabarakatuh.